the participants engage us via our Q&A section and also in our chat at the chat box section. So we request that you actively log in through the session and benefit from the wealth of knowledge with which Barbara is going to share with us. So Barbara, welcome to the stage.
Hi, everyone. Thank you for joining us today, and you're welcome. So today we'll be looking at burns, and we'll be having a look at nutrition in burns for us to be able to better understand the role of nutrition in burns. So when we talk about burns, what are we talking about? We are talking about an injury to the skin or other organic tissue that is primarily caused by heat or probably due to radiation, radioactivity, electricity, friction, or even chemical burns. So according to statistics, you find that 7 to 8 million people with who sustain burn injuries actually require medical care. And you find that according to WHO, about 180,000 of burn-related deaths actually occur every year. You find that also in Africa, over 1 million burn cases occur each year, leading to significant morbidity and mortality. So when it comes to the classification of burns, they're usually classified based on the depth and also the extent to which they occur. So we have the first degree burns, also known as superficial burns, and you find that they affect mostly the outer layer of the skin, which is the epidermis. Then we have the second degree, also known as the partial thickness burns. And this burn involves the epidermis and then also the dermis, which is found below the epidermis. Then we have the third degree, also known as full thickness burns. So these burns you find destroys the epidermis, destroys also the dermis, and then also goes into the subcutaneous tissue, which is the third layer. Then we have the fourth degree burns, which involves both the layers of the skin and also the underlying tissues as well as the deeper tissues, and possibly it could go up to the muscle and even up to the bone. So when it comes to estimating the percentage of burns, we have the Wallace rule of 9, which is a chart that is widely used to determine the percentage of the total body surface area that has been burnt. The chart usually divides the body into sections of 9%, representing the body surface area. So if we can have a look, we can see from the head, if you have a burn in the anterior and also posterior, this would make a total of 9, while if it's anterior only, it will be 4.5. If it's posterior only, 4.5. If we have burns at the torso, if it's the chest only, you find it's 9%. If it's chest and abdomen, then we have 18%. Then you can also have a look at the back, and then also each arm. So for each arm, if the anterior is burnt, then we know that is 4.5. If it's both the anterior and the posterior, then it makes a total of 9. And the same thing goes for each leg. Anterior will form 9%, the posterior will also form 9%, and the perineum will have also 1%. So the version here mostly is for adult patients. For pediatric patients, we have slight modifications in terms of percentage, but basically the same principles apply. So we'll be putting on a poll question. Okay, so we've put in a poll question. I'd like to know, for patients with bilateral lower limbs, who is estimated to have what percentage of burns? Yeah, so according to the poll results, we've seen that 32% have chosen 9, 18% have chosen 4.4, and 50% have chosen 18. So based on the Wallace rules of 9, the most appropriate answer is the 18. Is 18. So then we go to the next slide, which is now the pathophysiology of burns. Which is the pathophysiology of burns. So when it comes to burns, we find that there are 3 phases of injury that usually occur. So the first phase is the ebb phase, and this one usually occurs hours after injury, and it is characterized by a period of decreased metabolism and also reduced tissue perfusion. The second phase is the flow phase, which occurs days after injury and is characterized by catabolism, hypermetabolic rates, and also hyperdynamic circulations. We have the third phase, which is now the recovery phase, and tends to occur weeks after an injury has occurred, and this is the phase where now anabolism now starts to happen. Now, as we can be able to see in this graph that we have a comparison between sepsis, between trauma, and also between burn injuries. And as we can see, for burn injuries, the hypermetabolic response is much higher and lasts for a much longer time. For patients with burns, it can even take up to a full year for the patient's system to get back to normal, as opposed to maybe sepsis, which the body is able to get back to normal as quickly as possible, even through the trauma. So burns lead to a lot of hypermetabolic responses, of which we can see compared to other injuries. So when it comes to nutrition, now why is nutrition important in the burn patient? So first of all, you find that the burn patients will experience a lot of losses of fluids containing large proteins, proteins, minerals, micronutrients through the skin. And this can over time lead to acute deficiency syndromes of these nutrients. Then you also find the surface repair is also extensive, and this requires prolonged nutrition support, which is rare for other types of traumas Then we also tend to find that many burn patients tend to stay for much longer periods in the intensive care units compared with other forms of traumas. So this also increases their need or requirements for nutritional support. As we have also seen in the previous slide in the graph, you find that the hypermetabolic state will be able to last for a very, very long time, and this is up to 1 year. So this means that for the patient is at very high risk of losing their muscle mass. So when it comes to the goals of nutrition, what do we aim? First of all, we want to do fluid restoration. This is as burn injuries cause a lot of fluid shifts in the body, which needs to be stabilized. We also want to promote wound healing and also rapid recovery from the burn injuries. We would like to minimize the risk of complications, including infections during the treatment period, which could help reduce the length of stay of the patients in the hospital. We'd also like to attain and also maintain normal nutritional status, and also maintain the lean body mass, as most of these patients who have burns are very prone to developing muscle wasting because of the hypermetabolic state in which they're in. At the same time, we'd also like to try and reduce the metabolic disturbances that they may have during the process of treatment. So one of the first things that is very, very important is hydration of the patient. And this needs to be done within the first 24 to 48 hours. So the main aim of the fluid management is to re-expand the intravascular volume. We also do fluid management to help in delivering adequate amount of sodium in order to restore the cellular transmembrane potential. We also require the fluids to be able to replace the other extracellular electrolytes that have been lost, so as to be able to reduce life-threatening electrolyte disturbances, which can lead to cardiac arrhythmias. Then we also want to correct any hypoproteinemia and also increase the colloid oncotic pressure. As we've seen before, we find the patient is losing a lot of protein losing a lot of fluids, is also going to lose a lot of protein, which we need to also make sure that we are sorting out. So we have the Parkland formula, which is the most common formula that is used to calculate the amount of fluid that should be administered to critically burned patients over the first 24 hours post-injury. So now we'll go on to determine the energy and nutrient requirements. So below here we have a number of formulas. So what we need to appreciate is indirect calorimetry is the gold standard for the measurement of energy and expenditure. But in our current setup here in Kenya, you find that it's not feasible or very practical to be able to be done. So we have a number of equations that could be used to provide a wide range of estimated requirements. And we need to understand that there is no one method that is superior to another. It is based on on an individual's discretion as to which method to be able to use for their patients. So one should also remember that much as we have these equations, there are guides, and it is very important that patients should be reassessed on a regular basis, and the adjustments need to be made based on how the patient, or based on the patient needs. Now, for example, you find that for burn patients, the acute metabolic phase lasts about 3 weeks. So as this tapers off, you'll find that a more standard equation, maybe putting into account the injury and also activity factors, may be necessary in order for you to maybe avoid overfeeding during that recovery phase. So we have examples of various formulas which could be used. We have the Davis formula. So you find this Davis formula sometimes may overestimate the caloric needs. So you find it very suitable maybe for when your patient has large injuries or in the initial phases of treatment of the patients. We have the Toronto formula. As you can see, it puts into account the total burn surface area, the caloric intake in the last 24 hours, a Harris-Benedict estimation without the adjustment, and then also puts into consideration the temperature. This is the temperature that the patient experiences and also the number of days post-burns. Then we have the Harris-Benedict. For the Harris-Benedict, it helps to estimate the basal energy expenditure and can be adjusted and has an adjustment for both the activity and also the stress factor, as opposed to the other formulas. So when calculating requirements, it's also important that you need to consider the use of the ideal body weight or the usual body weight. So you don't randomly guess maybe the weight. And then you also need to reassess or maybe readjust based on how your patients are doing. So the reassessments of, for example, if the wounds you find are now healing, you may find maybe the patient requires less calories. So you will need to reassess and then reevaluate whatever method you've been doing. Then you also need to ensure that even as you put into place these equations, you need to make sure that you're having regular monitoring. And this is recommended at least twice a week to do a revaluation, and even daily reviews of the patient or every other day of the patient, to just be able to have monitor and to be able to have a follow-up. Then you also at some point would have to continue consider, for example, is the patient going through physiotherapy, occupational therapy? This will then mean probably they will need higher caloric, higher calories. So you will need to adjust as required. So then we have the Ireton-Jones equation, and this Ireton-Jones, we have two versions. It's very common. It's more commonly used in patients who are in the ICU, and we have the ventilated patients, and we also have the non-ventilated patients. So this is the modified Schofield equation. Then we have the Cureri. Then one of the things we need to appreciate is for the Cureri, this is both in pediatric, and we have a pediatric, and also we have an adult version. And we need to appreciate that most of the time, the Cureri often will overestimate the caloric needs. But again, remember, we adjust based on the patient's needs. Then for pediatrics, we have two formulas which are commonly used. We have the Galveston, and then we have the Cureri. So now, once you've been able to determine the energy needs of your patient, then now you need to proceed to delivery. So when you come to delivery, there are a number of factors that may determine the mode of delivery that you give to a patient. For example, if a patient has inhalation burns, you may find it may not be feasible to feed the patient enterally, and this may mean that this patient will now need to be put on parenteral feeds. Now, one thing we need to note is that the preferred mode of feeding is always the enteral route. This is not just for burns, but even for most patients. The use of TPN often poses a great risk to the patients, and especially for burns, you find the susceptibility to infections. Remember, most of the skin is being exposed. You find there's also a higher risk of these patients developing hyperglycemia because of the sugars that are found in the TPNs. And remember also, because of the burns, these patients are also prone to developing high sugars. You find it's also less effective in maintaining the gut barrier and the host immune function as opposed to enteral. So you find it also impairs the immunity of the individual and can also increase risk of liver function also. It can also pose a risk to the functioning of the liver. So you find using enteral will pose less risk to the patient as opposed to TPN. So if you consider TPN must be the last resort when any and every other method is not possible. Such as in the case, as I have mentioned, maybe if a patient has inhalation burns, you may find maybe it has affected the whole gastrointestinal tract. So you'll find it's very difficult for you to be able to give. So even when you're considering giving the patient, first of all, you need to see, given the calories or the nutrients that have been able to calculate, is it possible for the patient to take or meet those needs by eating or just the normal diet or just taking normal oral supplements? If you find that it is not possible, then you need to also look, is there an enteral method which I can use so that the patient is able to get the required or the recommended calorie needs? If you find the enteral is not feasible, then now you go into using the parenteral nutrition. So of things that you'll need to note, for example, is how also the state of the patient. You'll need to notice, is your patient in pain? If your patient is in pain, then you need to optimize on pain control, because then it means this patient will be unable to eat. Yes, they are able to eat or take food orally, but because of being in a state of severe pain, they are unable to meet their requirements, because you find they're unable to eat as much as you would recommend or as much as is required. At the same time, you have to also consider the pre-existing medical conditions. For example, maybe prior to developing the burn, the patient had renal failure, and you have to consider now that with the renal failure and what is happening with the burns, what would be the most suitable maybe formula for me to be able to give for the patient. Another thing you also need to have to look at is also the pharmacotherapy. You need to look at drug nutrient interactions. Are there feeds that I can give that maybe are contraindicated from being used with other forms of medication? Or maybe is there some form of medication that should not be used with? So it can be drug nutrient, or also the interactions can be nutrient drug interactions. So we'll be able to have another poll. Which you can have at least 30 seconds to be able to answer. Okay, so based on results, we see that 13% went for Cureri. We see that 20% went for the modified Harris Benedict. We find that 16% went for the modified Schofield question. 49% said all of the above, and 1% said none of the above. So when we're using the formulas, as we had mentioned earlier, it varies based on you and what you feel, but there's no one formula that is superior to the other. So the answer would have been for all of the above. Yes, so when we go to administration of nutrients now, when you go to the administration of the nutrients, we need to make sure that carbohydrates are giving us about 60 to 70% of the total energy. And you need to make sure that care is being taken so as not to exceed what the patient is able to metabolize in terms of carbohydrates. Then we also note that for using TPN, if our patient is using TPN, we should not exceed 5 to 7 milligrams per kg per minute. When it comes to protein, protein should make about 10 to 20% of total calories. And you find that most of these protein requirements are increased because of the loss and also because of the muscle catabolism that is also happening. So you'll find you'll need to increase the amount of protein the patient is taking. Then you find the protein can be given at about 2 to 2.5 per kg per day. For fats, they should make about 10 to 15%. And non-protein energy as fat, and of which at least 5% of which should be from linoleic acid. As we know, it is one of the anti-inflammatory fats that we have that are there. Then for the micronutrients, we have a variety of micronutrients which will serve different purposes in the body. So it's also important to remember that micronutrients also play a role in burn patients. They help to fight oxidative stress. You find they help to support the immune system. You find they also help to optimize wound healing. We have the vitamin A, we have C, We have the B vitamins, which we know are involved in the nervous system development, the vitamin E. We have the trace elements and also the vitamin D. One thing we have to appreciate is that most of these nutrients will work synergistically. So if you sort your macronutrients, you have your carbohydrates, but you don't have zinc, then you'll find there'll be an issue with the metabolism of the carbohydrates. So it's not to say that we should remember the micronutrients and then lock out the micronutrients. So we need to make sure that our patient is covered both in the micro and also in the macronutrients. So we'll have an example of a patient here. So this is an actual okay, so this is an actual case of our patient that we have. So we can look here and we see that the client history. Okay, so our patient is a 44-year-old male and he's day 0 in the burn unit. This is his first day in the on admission in the burn unit. So he had a diagnosis of 49% of electric burns, and these burns were found in the frontal left arm, the right arm, and both of the lower limbs. So when he came, there was no known previous history of any comorbidities. When we did his anthropometry, his weight was 75, his height was 165, and his ideal body weight was 60 kgs. So for the nutrition focused physical examination, we found that he was stable, he was on room air, he was oriented, his hair color was normal, there was no jaundice, there was no pallor, and his stomach was not distended. So his stomach was not distended. So in terms of dietary history, he was just admitted, so the patient was undergoing the fluid replacement as per the doctor's instructions. So this is just a copy of his biochemical data. It's very important, as was explained in the previous presentations that were done. Much as we look at the nutrition focused examination, it's also good for us to be able to appreciate the biochemical data that we are able to collect from the patients in order to help us to be able to come up with an intervention for our patients. So in this case, you find the sodium was low. Remember, we had earlier mentioned there'll be a lot of electrolyte, there's disturbances in electrolytes. You find a loss of protein and albumin. So you find our patient presented with low sodium. You find also presented with low chloride. Their creatinine was also low. We find they had slightly elevated liver enzymes, the AST and the ALT. And then if you look here, you're able to see his total protein was low, and also the albumin was also low. This is part of the metabolic disturbances that tend to happen with patients who have burns. So even as we come to coming up with a plan, those are some of the factors that we need to remember or put into consideration. Then we also look here specifically at the hemoglobin. You find it at 8.6. Again, you find probably this was affected by the burn, injury. So this is just how we came up with his energy requirements using different methods that we've been able to see there previously. So when we did the Cureri 1978, we came up with 3,460 kilocalories. When we did the Davis, we came up with 4,630 kilocalories. When we did the modified Harris-Benedict, we came up with 2,560. When we did the Ireton-Jones, we came with a total of 2,020 kilocalories. The modified Schofield equation gave us 2,564. So we are able to see that most of these equations will give us different amounts of energy. And as we had previously mentioned, you find that the hypermetabolic state will be happening maybe for the first 3 weeks. So you may find maybe at this case, you want to use maybe the Davis or Cureri because of maybe giving the higher calories. Then over time, you'll find as this high metabolic state is now tapering off, then you find maybe you want to use the modified Harris-Benedict, or maybe the Itons, or maybe the modified Schofield equation. Then we also have to remember that, as we had mentioned earlier, the modified Harris-Benedict also puts into account activity factors, because at this point you find maybe you're rehabilitating your patient in terms of doing the physiotherapy. You find maybe your patient was non-ambulant, but this time they're ambulatory. You find maybe your patient could not even sit up, but now you find they're able to sit up. So you'll be able to adjust as you see fit, or as you find suitable. So that is the end of my presentation, and thank you for listening. So in case of any questions, they are welcome.
Thank you very much, Barbara, for that great presentation. I think when I look at our Q&A section, there are participants who put across some questions, which I'll take you through in terms of what you want to clarify, or maybe get some response to. So Joseph Otora is asking this question: how do you manage burns in a diabetic patient? Diabetic patient, how do you manage burns if you present to a unit?
So one of the things you have to remember with a burns patient, and then having this burns, it will actually aggravate and maybe worsen the glycemia, or even cause almost uncontrollable hyperglycemia. So one of the first things you need to make sure that the medication will be optimized. You may find maybe if the patient was on oral drugs, you may find maybe the doctor will need to move maybe to insulin. That is, we'll have to move maybe to insulin, or what is it called? That is infused, or so that it's given at specific times. At the same time, you would have to do in terms of what the patient will be able to take orally. You need to give feeds where that are diabetic friendly. Basically, you'll find a number of formulas in the market that are specifically made for that are specifically able to provide low glycemic, the low glycemic feeds that are available. You probably have to use that.
Well, yes, it's true that burns also triggers progressive stress to a patient who already has diabetes. That's why, like as she had earlier mentioned in the discussion, that in deciding on what to give, first you look at also issues around other comorbidities that the patient could be having. So in this case, while that now diabetes is on point, then of interest would be in the distribution of the macronutrients. Then actually you will be looking at giving a lower scoring, like say 50% of the total CHOs, or the calories to come from carbohydrates. And in this case, if able to feed orally, then now you're actually looking at feeds that actually, whole grain, to allow for slow glycemic release into circulation. Or if you're doing oral nutrition supplementation, then you provide feeds that actually provide low glycemic, low glycemic feeds, or formula specific for patients with diabetes. And if you're giving also parentally, then also you can just in terms of if you're giving say glucose independently besides amino acids and fat, then the ratio of the total calories from carbohydrates also will actually be titrated to a lower margin. So now you allow for slow release of glucose into circulation. Thank you for that question. Now, Barry Raftas is asking, from which food do we get linoleic acid? Well, linoleic acid mainly is from vegetable oils. So in this case, you're talking about corn oil, talk of sunflower oil, the nuts and seeds. So mainly, it's a form of polyunsaturated fatty acid. So mainly plant-based. Anonymous attendee is asking, would the nutrition supplements you administer to our burns patients lead to toxicities? Well, the answer to that actually would be no, For as long as now you've done prescribing on the basis of right dosing, right? If you have to do constitution, you constitute the powder formulations. Of course, you just use the right dilution method to see it as per the provider's recommendation.
Perhaps to add on into that question, Anonymous, I don't know what exactly they mean by nutrition supplements, because from the definition of what a supplement is, it's supposed to something you add on top of what already the patient is taking, and of which it's not you're not giving super high doses to the patient. So you're supposed to be estimating how much of it they're taking in that, what is the need requirement vis-a-vis the actual that the patient is taking, and what is the deficit. Because the supplement is supposed to cover the deficit. It's not just supposed to be given blanketly to any patient simply because they have burns issues. Because if you were to compare a patient who has 49% burns and perhaps a patient who has 50% burns, even when it comes to now to the supplementation bit, it's going to be very different. Because you have to look at the needs basis based on whatever the patient is able to take vis-a-vis what are you targeting and the deficit, so that I can be able to calculate what is the right amount of the supplement to give to the patient. Thank you.
Thank you very much, Agri, for that additional input. Anonymous attendee also is asking, how do we go about the patients who are on other specific diets, let's say renal diet, and have burns? Sarah?
Okay, I'd like to say that patients who have renal failure, they are classified into two: those who have stable CKD or not on dialysis per se, and those who are on hemodialysis. So for those who are on who have stable CKD, we do recommend that you do a lower protein of less than 1.2, simply because you don't want to overwork the kidneys, however much you want to help in quick recovery of the wounds. But for those who are on dialysis and yet have burns, you would go at a higher notch of proteins, providing more than 1.2 grams per kilo per day. So it depends with what your burn requirement, as in your burnt percentage area, burnt surface area is in relation to whether it is stable or on hemodialysis.
Yeah, thank you for that. Yeah, I agree.
Well, to add onto that, remember, as you're evaluating your patients, please take key note about the issues to do with the nutrition focused physical examination that you do to your patients. Together, you augment it together with the biochemical parameters of your patient. Because remember, not two patients are going to have you're going to have similar same management to that particular patient, because you might get one who has parameters that are clearly indicating to you like there's more organ failure to the patient, and you need to be cautious in as much as you already know this patient is in a hypercatabolic state, but you giving the target would end up worsening the scenario. So it is patient dependent. So it has to be individualized to the particular patient whenever you're managing them. So there's never a clear line in terms of when you're managing a patient who has renal and burns, that this is the only way you go about it. So you have to clinically examine your patient. You have to clinically evaluate, critically evaluate now your biochemical parameters. What are they indicating? What is off? And then you're trying to look at what is the root cause. Why is it off? Because perhaps you might get like the patient is going into renal failure simply because he's not getting adequate fluid. So he's going into more of an acute kidney injury. So you need to look at now what exactly, what is more important to that particular patient that needs to be done so that you stabilize the patient first before you even start thinking about feeding the patient. Thank you.
Thank you very much. So anonymous attendee asking this question, why do the different formulas, that is the formulas for estimating requirements, result in different energy requirements? Could this lead to patient mismanagement in case different institutions use different formulas?
One of the things we had mentioned is that you adjust based on your patient requirements. So if your patient requires very high calories, probably you'd use them. If your patient requires lower calories, probably you'd use. So one of the first things you need to understand is just a guideline, and it doesn't mean it's exact or everything is cast on stone. Now, the other thing is at the time at which most of these formulas, for example, the Cureri formula was used, you find that there was not the same kind of advancements that we have in medicine currently. So you'll find over time, there are certain measures that are taken for some of these patients, which can actually reduce the requirements for some of the nutrients. And that's why you may find we have the varying amounts of kcals, basically, of energy. Yes.
Yeah. So
Okay, to add it on top of it, it's all about the pathophysiology of what occurs in burns, as through the presentation we've been taken through in terms of the different phases of this particular patient. So it depends now, at what phase are you in? Are you in the acute phase? Are you in the chronic phase? Or are you in the recovery phase of treatment of your particular patient? Because you already know, in the acute phase, there's now the disturbances within in terms of that destabilizes the physiology of your patient, which is giving you issues to do with hypermetabolism. There's a hyperglycemia, of which you would want first to control such. And they usually say it lasts around a week or so, or less than 4 days, or at least a day to 4 days. It is never actual. It is not an exact thing, because different patients have different mechanisms of how long it's going to last. So if you're taking that into consideration and trying to look now into the pathophysiology, even as you're deciding on which particular formula to use, then you can clearly evaluate at this particular stage, based on now the clinical findings and based now on what the biochemical findings are showing, then I should be able to tell you, perhaps, even if I decide to use now the Cureri formula, the way I would want to initiate my particular feeds for this particular patient, I'd rather go slow as the body tries to stabilize, so that now I go on increasing gradually. The formulas are there to help you estimate the energy requirements or the nutrient requirements of the patient. They're not actually telling you how much the patient would need. What is the actual? It's just trying to estimate, it's just trying to give you a guide, even as you're managing your patient, on how to go about it, but doesn't really sort of like say you have to do it this way. You're the one actually who decides which is the best way to go about based on now the evaluation you've done to the patient.
I think I agree. You rightly put it that the formulas are out to guide in terms of estimating requirements. Otherwise, you'll find that if you have to definitively get what the patient requires, then you actually require to do the indirect calorimetry, which now in this context, you find that setting up a unit of that nature is a cost. But of course, as we grow as a country and even I suppose as a center of excellence in burns care, of course, at some point in time we'll be able to do that in the future. But either way, remember, in as much as there would be a situation whereby some formulas overestimate, the issue of interest here is your times you may find that it could also be a blessing in disguise in terms of, for instance, there could be interruptions in, like, say, feed administration. So in as much as, yes, you would have actually overestimated the period with which the patient actually has gone for a procedure, is actually maybe undergoing, an investigation, then the supply they have received actually will be of benefit. But at times in the event also, if the startup volumes are so high, then actually you may also end up into implications related to enteral nutrition, like say diarrhea or maybe feeding syndrome. Now, so no superior formula, but a guide on where to start. Then you scale up case by case as your patients respond to the intervention at hand. Another question from Techno, come on. Somebody has decided to label themselves by the gadget they are using. How do we estimate the fluid replacement need? And I think as projected, the presenter talked about the Parkland formula. Usually, of course, depending on the immediate phases. There are protocols to guide on how do you start in what time frame, but then progressively with the time, the volumes will be changing as per the patient's response. Therefore, of course, the Buckland's formula is the empiric formula for estimating how much you should replace. There is also Mwiti Makadimo. Thanks for the compliment. We welcome your compliment as well. So Anne Mushina is asking, should we use the ideal or actual weight? Anne Mushina, should we use the ideal or actual weight?
Sometimes you can, depending, you can use the actual weight, but most of the time it's good to be able to use the ideal weight because, for example, if your patient is underweight, your nutrients are targeted towards getting them towards the ideal weight. So personally, I would prefer to use the ideal weight, ideal body weight.
Well, to add into that, at times you get like whenever you're trying to use the actual, simply because when you try using the actual, you usually get like they usually dress those burns wounds, and that will usually contribute to the increase in weight in that particular patient if you want to decide to use the actual weight. So it's a catch-22 scenario whereby when you're having a patient who has been dressed up, the wound has been dressed up, it adds into the weight of the particular patient, so it might end up giving you an overestimation whenever it comes to now to the nutrient requirements of the patient. So perhaps an ideal body weight would give you a better estimation as to the needs of the particular patient that you're having. But also look into the context of the particular formula that you are using. It is advising you use which particular weight, because there are other formulas perhaps you'll see, like if you're to use now the Schofield's formula, it would, especially in pediatrics, it will tell you you're supposed to use the actual weight, but also you have to have that perspective, that critical thinking skills in terms of if your patient is having all these dressings and you're trying to use the actual weight, are you actually, is it actually going to give you the requirements of this particular patient, or is it going to overestimate or underestimate? So it has to be, it all boils down to you particularly to make that particular decision. It's not more of like a clear-cut answer. For those who do not have those heavy dressings, perhaps you might want to use the actual weight.
Thank you. Anonymous attendee asking this question: how do you manage a burn which is just a scar, which happened long ago, but sometimes using some parts? I mean, applied to at least reduce scar. Well, actually, what I would say is you need to seek health, review by a clinician, so that now they also can find out what could be causing it. Because long ago, or even if it is 2 or 3 months ago, of course, when there is pus coming out, then query if there is an infection active, or maybe in some cases you may find somebody even has undiagnosed conditions like diabetes, which actually will be exacerbating delayed wound healing. So seek the services of a clinician for evaluation and therefore a definitive treatment. Then there is Collins Mutai. Mutai is asking, first is complimenting the presentation. Thank you. Can we give glutamine therapy for 3 days for burns patients, especially those with more than 60% burns? Can we give glutamine therapy for 3 days for burns patients, especially those with the 60% burns? Sarah?
I would say that first of all, you have to check the biochemical parameters to determine whether there's maybe an acute phase of maybe AKI, liver injury, because in such situation, we usually don't give glutamine. It's actually contraindicated, and whether there is infection as well. Thank you.
Thank you. Daisy Kubende is asking, what are the best supplements for burn patients with malnutrition? malnutrition. So Daisy, the first place, malnutrition is either over or under. But of course, you find that I want to presume you're talking about undernutrition. But either way, as you've said earlier, that depending on your assessment, and therefore a patient if has presenting comorbidity, then there are select interventions you'll use to target the condition at hand. So for instance, if a patient is diabetic, there are formulae for use in that line. If he or she has a real liver problem, there is also formulation to that direction. So it's diverse on the basis of the presenting underlying medical condition, or even if there was no history of liver or kidney failure, in the trajectory of patient care, you may find that derangements in, say, the lipogram or the liver panel will actually now see a switch in the intervention. So, not a definitive answer to the question, but as in it's based on a raft of factors that what you want to settle on a prescription in the case at hand as it presents. Another question is, what formula do you recommend as the expert to encourage standard practice?
I think Agri had touched on that, that it varies. So there's no one formula that one would say use Cureri or use Galveston or use Davis. It's based on your assessment, what you feel is suitable, and also based on at what point of treatment is this patient, and is it maybe in the acute phase? Is it maybe in the recovery phase based on that? So we cannot say that there's a particular formula that we can recommend for you to use.
Yeah, well, but when you look at those formulas, basically you find that depending on how easily you can manipulate, and therefore you have an output based on the workload. Of course, in some way you may find majority settling for the Cureri by virtue of the fact that you simply type in and therefore you have an answer with you. So as busy as a center can be, then you find that yes, the Cureri may nearly seem to top the options, but are slightly put no superior out of the mentioned. Now, still a question on the same is, do we have an African-derived formula to calculate kilocalories requirements? Well, I would say no, but either way, you find that race does not really change human anatomy. So whether you are from the Asian community, European or African, we nearly, the example could be, now we look at the blood groupings. I doubt whether there is a different blood grouping for the Asian and the European communities other than also what is available here in Africa. So I think either way, whether it's derived local or it's imported, the need here is a ban. So there's no way a ban in Africa will be different from a ban in Asia. Either way, they're just out to guide. So because either way, even if you have to have a local one, still there will be dynamics around whose is superior to the other. But of course, it's also it opens a good debate. So now we talk about African Academy of Sciences, then they will actually be able to delve into such gap areas to be able to see near homegrown solutions to the issues that we face. Yeah, so another question. Arafa Mkumbo is asking, I didn't note something in flowchart. What does this mean? Oh, she noticed that in the flowchart there was less than 25% ban. What does this mean? When you look at that flowchart, you find that depending on the degree of bans, and now you like say in your evaluation, a patient has a bans of less than 25%. So if the patient has less than 25%, and then the answer is yes, then the next assessment is it possible to give oral? So then it's actually helping you to decide on the mode of feeding for this particular patient independently. So then now if above 25%, then the answer of course will be no, which means now the severity of the ban, if you are to try and feed orally, there will be challenges in achieving that. That's why below 25%, you will find that yes, these are patients who are able to feed. But if they are not able to feed, then still maybe you're having less than 25%, or maybe they also had trauma, maybe out of a road accident, maybe on top of the burns that they succumbed to, then, or they lost their level of consciousness with the low GCS. Yes, it's below 25%, but now the others, issues of it, let's say now the level of was aiming at. So the percentage actually was aiming at helping you decide on the mode of feeding for these patients. So the lesser the percentage, the higher the chances that now this patient is able to eat orally. But as the percentages go higher, then specialized interventions in terms of feeding need to be implemented. Another question? So apart from somebody is asking, why do we use Parklands to calculate fluids, no other formula?
Parklands is the most common formula that is used. It's the most common and acceptable formula that is used.
Well, of course, other than Parkland's formula, you find that there is also what to call the 1 ml per kilocalorie method, whereby if you are giving, say, 2,000 kilocalories, you'd actually give 1 ml of fluid for every energy you supply to the patient. Of interest here is you are simply meaning that for every garbage in, you have fluid to help also flush out that very, garbage out. But then, of course, conventionally is the preferred formula in this context as pertains to burns patients. Of course, one also would say maybe, although this is so predominant in pediatrics, so now you say maybe for the first 10 kgs, you give 1,000. For the next 10, you give, say, 50 ml. Then anything above 10, above 20, now you do 20 ml per kg. But either way, now, conventionally, what consensus among the experts has been that Parkland is what has been suitable in the context of burns. Somebody is asking, why are burn patients so prone to sepsis? Why do many die? Well, sepsis, remember, the skin is the top immune defense system for any human being. That's why once the integrity has been compromised in the context of burns, then chances are you've opened, an avenue for a broad spectrum of infections that actually would see the patient become superly at risk of infections, and even to some extent, if not well managed, then death can be near obvious. That's why in this context, we find that if, say, as a nutritionist, you come in the context that now the patient requires high energy, high protein diet, so that now you want to put off fire with fire, as in more calories, yet the patient is not hemodynamically stable to handle, then obviously mortality can also be high. Talk about also matters hygiene in the center in terms of nursing care, proper administration of medicines, and again also if there are any other underlying comorbidities, Then, of course, if not well taken care of, then mortality becomes near obvious. That's why we say that a cautious approach in management is key. So that in as much as yes, you'll have determined your requirements, but then now remember it's a scaled approach to delivery for as long as the patient becomes hemodynamically stable. So get to understand at what stage of the burns trauma is the patient in. In the acute phase, feeding is not an emergency. That's why if you are at that time now, on day one, you're giving 2,000 calories at one go start, then of course, matters, metabolic derangements will set in. But as the burn ages, then the severity of risk becomes smaller on the basis of how did you initiate your feeding. So don't react to the burns, but rather act on the basis of patient dynamics and tolerance, so that now you can see the mortality go under, at the same time also shrink the sepsis. So, and remember also in burns case, have multidisciplinary team, meaning let the insurers do their part, the nursing team, the surgeons, and any other specialists of interest, so that now eventually, holistically, we have a collective output from that center or unit. Somebody is asking, can you talk about refeeding syndrome, especially if a patient is underweight and you are using one of the formulas giving more calories? Well, I think it's connected to the discussion I've just concluded. You find that repeating syndrome will set in, especially if in the care of advanced patient, you come in as reactive rather than being proactive. Reactive to mean, for as long as you've seen a wound, patient is underweight, then you're like, they came to the ward to gain weight. Gaining weight wasn't the emergency, but rather if their physiological competence at par to meet the interventions you want to put on board. That's why in this case, what actually is of interest is, we talked about what weight do we start with. Yes, the ideal weight will give us the target calorie requirements for this patient. So even if the target was 2,000, now you don't aim at 2,000 from the word go, but rather scale up from say 50% onwards to target. That's why like biochemical assessment, as earlier alluded in terms of now looking at say the potassium levels, phosphorus and zinc, the panel, you get to see hyperglycemia, is this present or not, can actually help you to assess on whether you're actually on the verge of heading towards feeding syndrome. So cautious feeding is the key to averting feeding syndrome. And in this case, you find that the formula to use will be based on now on the formula in terms of the intervention, not the formula in terms of calculating requirements. So even if you used Curie and then you put 3,000 as the calorie target, remember you don't feed 3,000 day one. But even if yes, the patient now has also a medical condition, say diabetes, then you wouldn't give a conventional powdered formulation, but rather you'll give a supplementation that is of interest in actually addressing hyperglycemia, but progressively transition your feeding volumes towards 3,000 as rather based on the patient's tolerance over time. And that's why interventions in advanced patients are progressive, dynamic, not a one-stop shop in terms of now you've done a prescription, so you will actually be looking at the patient's response long-term. It's not static, it's dynamic, that is. Question. Karen Zawadi, what is often given to burn patients to meet calorie needs? What is often given to burn patients to meet calorie needs? Well, from the flow diagram, we find that if the patient is able to eat, like say below 25% on your assessment, the patient is able, like say ambulant, able to talk, then they can actually be given regular family food or kitchen food. But then now we could do supplementation based on the specialized formulas for that purpose. So in this case, but remember, as my colleague had mentioned earlier, you supplement to meet a deficit, not as a conventional prescription. So able to feed, then give kitchen feeds. But in the event they require maybe enteral or parenteral support, then you give formula specialized to address the presenting metabolic challenges for that particular patient. Thank you.
Well, to add on to that, we are not saying it's going to be a smooth sailing whenever you're managing a patient. And perhaps as you're seeing your patient, you should always anticipate challenges along the continuum of patient care, because the hemodynamics will be different in different patients. So you get like there are patients perhaps who will come in not able to even swallow, and others perhaps they're already coming in already malnourished, others perhaps they're already coming in well nourished. So along that continuum, there you're bound to get challenges around it. So how you go around those challenges is basically based on the information that you have physiologically. It's more to do with the physiology, the principles of physiology. What is off in this particular patient? Then I'll try to dig into determining what is causing it to be off, looking for the cause. If you look for the cause and try to mitigate or try to sort the patient from a causal sort of point of view, you're likely to succeed. But when you want quick and short interventions that you want to institute faster, you end up contributing to the morbidity and mortality in this particular kind of patients, because challenges are bound to be there. That is given, especially in advanced patients. So you should try to anticipate for them. Try to look into them in terms of perhaps if you're getting a patient who is having hypokalemia, perhaps it might bring about the issues to do with paralytic injuries in your patient. So if you don't intervene by supplementing the hypokalemia in your patient, and they're busy concentrating on caloric requirements of the patient, you will see you're not likely to succeed, because it impedes the gut integrity of this particular patient. So whenever you're trying to feed the patient, you'll be able to achieve what you want at the end of the day. So you being able to anticipate those challenges and trying to sort out those particular challenges will greatly help you manage this particular patient, rather than having formulas, because you can have 1,000 formulas, because especially in burns, there's a lot and lots of formulas, ranging from the Ireton Jones, the WHO, the MERS, the modified Schofield, to the Cureri that we're talking about, of which it's more or less to read into the context. Because remember, all these formulas are formulated from a context. And whenever you're doing research, there's usually that component of who are your study participants? Were they adult patients? And then what brings in the other key question would be, at what point of, let's say, perhaps their bands, were they recruited into this particular research? Is it at the acute phase? Is it at the flow phase? Is it at the recovery phase? Because you see, all these have the dynamics into it, or if were they all lumped together in this particular to formulate this particular formula? So you can see there's quite a lot of the dynamics that are not usually put across whenever you're seeing these formulas there, that you have to consider when you're managing your patient for you to be able to succeed, to have a positive clinical outcomes in your patient. So that has to be at the back of our minds. That challenges will always be there. It's up to us now to try to look at now the physiology of the patient. What is it communicating to us that we need to adjust so that we'll be able to assist the patient? Thank you.
Thank you very much, Agri, for that input. I think Peter Mang is asking, is there any criteria used in dressing burn wounds? I think for the purpose of this discussion, we're looking at nutrition in burns. So I think we'll actually do research and programs organized on matters wound care. And I think, of course, there are existing protocols to that. So I think your question will be ultimately addressed come that time. Madam Edna Warento, she's saying congratulations, Barbara. I think thank you for the compliment, Madam Warento, for your attendance. And I think so far we've been able to address most of your questions. But now there's somebody, Abdi Ibra, who's asking, in pediatric fluid resuscitation, how do we go about it? I think the Parkland formula still applies, as earlier mentioned, or you could do a kg based dosing. So like you could say for the first 10 kg, you do 1,000 for additional 10, do 50, and then for the any other above that you do at 20 minutes per kg. Maybe I agree with something.
Well, let's comment on this issue about fluid resuscitation. Remember, you are more of an interdisciplinary setup whereby you're managing a patient. You're not managing a patient in isolation. So you're not saying it is your role to calculate the fluid resuscitation for the particular patient. It's more of a discussion you're having as a team in terms of based on what we are assessing, based on what the pediatrician is seeing, based on what the surgeon is seeing, or based on what the wound specialists are seeing, and based on what the clinical evaluation you've seen in the particular patient, which is the best way to move around this issue of fluid resuscitation. Because you find, like in pediatrics, depending on the age group that we're talking about, are we talking about an infant? Are we talking about a 12-year-old? Are we talking about a 16-year-old? Because all these are pediatric, and how you handle them would probably differ when it comes to fluid resuscitation. So at this particular juncture, you'd want to involve, you'd want to work as a team, don't work in isolates. Because whenever you work in isolates, you're bound not to succeed, because you're bound to have arguments around the patient management that are not going to be fruitful, because everyone is trying to blame the other. But when you work as a team, all of you are agreeing on the way forward, it becomes a bit easier, and you learn a lot from the management of the patient and how to improve the success rates in your patients. Thank you.
Maybe the last question, no, second last. Robert Kembo is asking, apart from the linoleic acid, you mentioned vitamin A and C, which falls under this group of antioxidant beef. Therefore, how can you administer the vitamin A and C? Well, you find that for vitamin A, there is, there are commercial options, like say Vitalipid Adult. So it has got both it has the water soluble vitamins, not water soluble, but rather fat soluble. So A, D, E, and K. So if you're giving parentally, you could give IV by the parenteral formulations you are administering. And for vitamin C, of course, as an injectable, or as part of, you would actually want to give it in isolation. For instance, you could give maybe say Papimex 1-2, which actually has both the water soluble vitamins, the B complex, and vitamin C. That will actually be able to see you reach out to your goal for vitamin A if you're supplementing, and C. So either whether you're giving it parenterally or independently, you can actually give them as injectables if are sure for certainty you are sure that the patient is not able to get enough out of the food or the other supplementation you're giving. So only supplement if it's expressly, there is an express need, but in the context of parenteral feeding, then of course you could really have them added to the formulations you're giving. And then the other question is, how will you manage a patient who has renal issues, anemic and has SPANs? I think this one we addressed last time, during this session. Yeah, so I think, thank you very much, participants, for having joined us this afternoon for this session. And we pray that in some way or another, you've learned something out of this discussion. So we welcome you for our progressive webinars in the subsequent months ahead of us. So thank you for joining, and God bless you.